Hi, my name is Manali Kamdar. I am an associate professor at the University of Colorado. On behalf of my co-investigators and the TRANSFORM study team, I have the opportunity to share with you the 3-year follow-up of the randomized phase 3 pivotal TRANSFORM study that investigated lisocabtagene maraleucel, which is a CD19 CAR T-cell therapy construct, versus standard of care that entailed salvage chemo followed by an autotransplant in responders in patients with high-risk relapsed refractory large B-cell lymphoma. In the pre-specified interim analysis at 6.2 months median follow-up, the TRANSFORM study met its primary endpoint, which was event-free survival. EFS was statistically significant and superior in the lisocabtagene arm versus standard of care. Complete response rates, as well as progression-free survival, was also statistically significant and higher on the Liso-Cel arm versus standard of care. The FDA approved Liso-Cel in the second-line high-risk relapse refractory setting for large B-cell lymphoma based on this interim analysis. As a follow-up to that, the primary analysis of the TRANSFORM study, after a median follow-up of 17.5 months, confirmed the superior efficacy as well as safety of Liso-Cel over standard of care in this high-risk patient population. Thus, herein, I report the results at a median follow-up now of 33.9 months. Just to quickly familiarize the audience with the study design, the key eligibility criteria were patients between the age groups of 18 and 75 with high risk, meaning primary refractory or early relapsing within 12 months of frontline chemoimmunotherapy, large B-cell lymphoma patients who had an ECOG of 1 or under and transplant eligible. They underwent screening and leukapheresis and then randomized in a 1:1 fashion to getting Liso-Cel at 100 million CAR T cells versus standard of care that entailed 3 cycles of salvage chemoimmunotherapy followed by high-dose chemo and autotransplant in responders. 92 patients were randomized in each arm. It's important to highlight that bridging therapy with chemoimmunotherapy was permitted on the Liso-Cel arm. 63% of patients underwent bridging therapy. Crossover was built within the study, and on the standard of care arm, 62% of patients underwent a crossover to receive Liso-Cel. At the 3-year follow-up, there are 47% of patients who are on the long-term follow-up on the Liso-Cel arm and 27% of patients on the standard of care arm who are now on follow-up. With regards to demographics and baseline characteristics, they were fairly well balanced between the two arms. 3/4 of the patients in each of the arms were primary refractory patients. And as the audience knows, these patients have poor outcomes based on the previous standards of care. So now at a median study follow-up of 3 years, the event-free survival, the median is 29.5 months versus, for standard of care, 2.4 months. This translated into a stratified hazard ratio of 0.37 and a 36-month EFS rate for the Liso-Cel arm to be 45.8% versus 19% on the standard of care arm. There were no changes in response rates. Complete response rates have always been higher on the Liso-Cel arm versus the standard of care arm. With regards to duration of response, so responders on each arm, how did they do? On the Liso-Cel arm, the responding patients had a median DOR, which was not reached, versus on the standard of care, on the autotransplant arm, for the responding patients, the median duration of response was 9.1 months. This was at a hazard ratio of 0.6. The progression-free survival was also higher, with a median PFS of not reached in the Liso-Cel arm versus 6 months in the standard of care arm. With regards to overall survival, it was numerically higher on the Liso-Cel arm at 62.8% versus 51.8% on the standard of care arm. However, the medians are not reached in both of these arms. Again, to remind, 62% of patients underwent crossover from the standard of care arm to Liso-Cel. Adverse events, there were no new adverse events seen. With regards to any grade 3 or 4 adverse events in the post-treatment emergent period, 9% had these events in the Liso-Cel arm and about 5% in the standard of care arm. There were no increased risk of second primary malignancies on the study on both of these arms, and none of the SPMs had T-cell lymphoma. Deaths on the study, there were a higher evidence of deaths on the standard of care arm, 46%, versus on the Liso-Cel arm, 37%. There were no new risk factors outside of that. Again, to remind the audience, with regards to CRS, they were all low grade. There was only 1% grade 3 CRS and only 4% grade 3 neurological events. There were no grade 4 or grade 5 neurological events. Thus now, at a median follow-up of 3 years, the median EFS, PFS, duration of response continue to be longer and statistically significant. The overall survival is not reached in either of these arms. However, it is numerically higher on the Liso-Cel arm. The safety results remain consistent with the prior primary analyses, and thus Liso-Cel as second-line treatment in patients with primary refractory or early relapse large B-cell lymphoma continues to show evidence for long-term disease control and curative potential. Thank you.